I'm very proud to introduce our distinguished alumni speaker, Dr. Todd Milbrandt. He's a chief of pediatric orthopedic surgery at Mayo Clinic in Rochester, and he has 25 years of experience treating some of the most complex pediatric musculoskeletal conditions, including scoliosis, clubfoot, patellar instability, and pediatric fractures. He's a researcher. He's a true clinician scientist. He was behind me in residency by 2 years. He's a very dear friend. We were at each other's weddings. Our families grew up together, and he's truly a remarkable alumnus, and we're very proud of his accomplishments. He graduated with a Bachelor of Science in Biology from the University of Puget Sound and graduated from UVA School of Medicine and completed his orthopedic residency here. He did his pediatric orthopedic fellowship at Texas Scottish Rite Hospital with Dr. Johnson. And most importantly, he reached the culmination of any orthopedist career. In 2024, Dr. Milbrandt became the 41st president of the Pediatric Orthopedic Society of North America. So this reflects his leadership and commitment to advancing pediatric orthopedic care. So Todd is a dear friend. We went through a lot together as residents, and very proud to have him here as our distinguished alumni speaker, and looking forward to hearing what he has to say. And congratulations on such an illustrious career, Todd. Very proud of you.
Well, I think our talk is going to fit nicely into the debate that we heard earlier about scoliosis, but we're really here to celebrate being a part of the Virginia family. I am a spine surgeon, so I might not be able to work this thing. Down, there we go. I do have some consultant work, but none of this actually is relevant today. None of these companies make what I'm going to talk to you about. But this is where it started. I matriculated at this at the University of Virginia in 1993. I graduated in 1997, and sometimes we get big snows, like you guys know here. But I was lucky to be a part of it. Charlottesville, we were just talking about this last night. At that time, Charlottesville was full of Dave Matthews and small college town vibe. It was not really what it is today. It's a semi-retirement community, a place where people move from the north to get away from the snow. And at that point, it really was the college and the hospital that drove the main parts of the city. And here I was, a kid from the West Coast, trying to figure out what all these important people were about. And I was part of this orthopedics class that included Dr. Miller, and who I learned a lot from. But we're going to talk a little bit about it, because even then it was very much a different place. I did a general surgery internship. And I asked, well, do I get to do orthopedics? And they said, well, you're going to do orthopedics the rest of your life. So for the next 4 months, you're going to be on TCV. So I hope that you like that. And during that internship was also the same time that it was a Q2 rotation, and my other person that was my partner quit. So that meant that for the next 7 days in the burn unit, I never left the hospital. And so these are different realities that our current residents don't face, but definitely taught me how to celebrate the people that were in this picture. So this is when we all received our blue jacket from Doc McHugh. We have lots of famous people in this picture that you can see. Many people are actually here: Eric Neff, Tim, Sonny Gill, Bobby, and Anna was also a big part of that too, who is a good friend, and Frank is in the back. So this was actually, if you think about it, a very foundational class for who makes up your current faculty. And there we are at graduation. I don't know if you guys remember who our graduation speaker was, but it was very fun and entertaining. But who I was hoping to see most was Tom Brown, because he still has an amazing mustache then. I'm not sure there's anyone who has a better mustache than Tom Brown. But at my, like Bobby said, at my wedding, there were other people. Bob Zura, I don't know if you guys know who Bob Zura is, but he's the current chair at last year. Oh, there you go. Awesome. So you guys have met Bob Zura, but these were people who were my quote big brothers in orthopedics and really taught me how to do what I do today, which was take care of patients and make sure that I stayed in line. Yeah. Damn good. I know, yes, you did, Bobby. And I appreciated you coming out. So this is over in Orange, and I have unbelievable memories. Charles was also a place where I started my family. This is my wife, Mary Beth, and we had 2 of our children here. If you haven't done Halloween on the lawn, then you haven't lived. But also, really, what it was about strong mentorship. David Educk took a big risk and took a kid who didn't really have much science background and put him in the lab. And with Dr. Wong's guidance and Dr. Gary Balian, we were able to do some great basic science work. And it was really the foundation of my scientific career. Dr. Abel and Dr. Blanco were the pediatric orthopedic surgeons that were here at the time. And they both guided me towards this crazy world where you get to operate everywhere and take care of kids who hide under the tables in clinic and really can create joy within pediatric orthopedics. And then there's Bobby, who I would consider, at least in my early pathway, the person who helped me figure out that orthopedics was for me. I remember I was a third-year medical student on my general surgery rotation, and Bobby was an intern. And UVA at the time had one of the first electronic medical records for ordering. You couldn't put in the written notes, but you could order things with a light pen. And he was sitting there putting things in a light pen, and he made an announcement. It was a big thing. I don't talk to any medical student unless they're doing orthopedic surgery. And so I thought, well, I'm going to give this one a shot. And so I went up and I started talking to Bobby, and Bobby had already printed out, of course, in true Bobby form, a page of how you get into orthopedic surgery, 1 through 15. And so he was the one that gave me that page, figured it out, showed me what I needed to do, and really helped me along my way. And I would be remiss to not acknowledge Dr. Wong, who I'm so glad to see today. But he's the one who called me to offer my job in my residency. He's the one who guided me to do both basic science and clinical work, which really I've taken to heart throughout my career. We're going to talk about innovation today, but the seeds of the innovation really started here at the University of Virginia with me. So I was in the lab for a year, and Dr. Educk and I were trying to figure out what we were going to do with articular cartilage defects. And in that laboratory, we started working with transfection, which at the time was brand new. No one really knew what that was. And so we took these cells and we made them glow green, and we put them into osteochondral defects in rabbits. And that was really what I spent my year doing. And we had some success. Kai Mirish, who you guys know as well, followed me in the lab and took that same project and created a JBJS article. But it was in that trying to come up with creative and interesting ideas on how to move the science of orthopedics forward is really what started me down this pathway. And many times in orthopedics, sometimes it starts with a patient. And so I've had, in 2015, I've been in practice 10 years. I kind of knew what I thought was working, what I didn't think was working. But in 2015, a patient went from Minnesota to visit Philadelphia, where they were doing this operation called the tether procedure. At the time, the Philly Shrine was really the only place that was doing it on a regular basis. And that patient came back to both Dr. Larson and I and said, I want that operation, but I want you guys to do it. And so that was really the start of our VBT journey. It was a high stakes, but a very motivated patient who was willing to take the risks along with us, because she did not want this. And you guys heard this already before, is that people don't want fusion, but we don't really have a good alternative. We have this sense that if you leave a big curve, it's going to progress with time. So we need something in between, and that's what this is trying to try and solve, is the in-between space in scoliosis, between fusion and nothing. And so what holds us back, especially in pediatrics? Well, we have this ethical concern of a proxy decision. It's the parents making decision for a child that then decides for the rest of their life what has happened. And so we have to get over that part in pediatric orthopedics, thinking that maybe what we're doing is going to help generations of kids afterwards. We also have to make sure that we create a safety net around us and study our results. And that's a big thing that we'll talk about today. It does take creative thinking, but someone has to go first. Someone has to be the first one that jumps off the raft. And you have to decide if you are going to be that person and how you can do it in the most safe way. In this case, it's a life jacket. And for me, it was making sure that we were going to create a great team and then follow up with published results so that everyone could know our risks, benefits, and troubles. There are things out there that can stop innovation, and we have to be very careful, make sure that we have our ducks in a row, to make sure that things like this don't stop us. And then we also have to interact with the FDA when it comes to innovating, especially if you have a new product or a new procedure. And we did that. I wouldn't say it was easy, but we went down that pathway. So scoliosis, we had a quick, brief discussion about it. It's a three-dimensional deformity. We think we understand it, but we really don't. I think as we get more ideas about how to do 3D reconstruction, we can actually start to think about what causes and drives scoliosis. But we have great observation. We're smart people. We can see what happens to these patients. They have a big curve. They have rotation that you can see. And what are we really trying to do when we're trying to figure out what to do? Well, we can either have observation, bracing, or surgery. Those are our options. We look at how severe the curve is and how much growth is remaining. We put all that in the computer. But the bottom line is that these kids, especially if they're young, they have a growth plate. And can we manipulate that growth plate such that we can get correction of the scoliosis? We know Ian Stokes has wrote about the vicious cycle, which is really just the Hutter-Volkmann principle, which is if you have some asymmetric growth and wedging of vertebra, that will then lead to more asymmetric loading, which will then lead more to spinal growth. And you have 10 to 20 degrees a year progression in someone who's growing very quickly. So it can go from a relatively straight spine to a relatively crooked one. And once it hits that threshold, which is probably around 35 degrees, then you're going to drive that scoliosis even further. Well, can we manipulate the growth plate? Well, we can, because we've shown it in both casting and in bracing. So here's a child who has a very large curve as a baby, and we can cast that over time and create, hopefully prevent having surgery in a child who's now 7. Same thing here, very large curve, but with casting, here she is now at 8 years old, and we've manipulated that growth plate. We haven't put any instruments, we haven't put any spinal implants in, but I would argue that we've tried to get the growth plates offloaded on the concavity. We also know from Stu Weinstein's, one of the only orthopedic publications in New England Journal of Medicine, which described bracing worked. In fact, they stopped this trial because bracing was so effective. So the 3 people were braced to prevent 1 surgery, which is really the concern about this paper in my mind. So when we think about it, we describe it as guided growth for the surgery, for the spine, but in reality, what we see is probably less guided growth and more just holding where we get it. But in our minds, the surgical indications are you need at least 1 year of growth remaining. The curve has to be 40 to 70 degrees, and they have to have no kyphosis. In addition, they really have to be a flexible curve. This is Mayo Clinic. This is one great thing about Mayo is you can ask them to do beautiful drawings. I would say this is a fantasy, quite frankly, unless you get someone who is very young. So if you tether someone who has open triradial cartilage, you might get this amount of growth modulation. But for the most part, our teenage kids really don't modulate this much. So back to our principles of innovation for this, we created a team. It was both Dr. Larson and myself. We're both pediatric orthopedic surgeons, and Dean Potter, who's shown on the right. He is a very talented pediatric general surgeon. He helps us get to places that we would think we could get to, but then makes it safe for us. We also decided to navigate our screw placement to make sure that we didn't have any malplaced screws. We also decided to go slow and publish our results and learn from our mistakes. We created a culture of safety where we recruited a good peds general surgeon. We did one, and then we literally waited an entire year before we did the next one. And then we set up a surgeon-directed IDE so that we can look outside of ourselves, and I'll describe that in a little bit. If you don't know what that is, it's basically a submission to the FDA, because at the time, Denassist, which was the system that was out there that had a flexible cord, was really for posterior work. So we had to petition the FDA so that we could use it anteriorly. This required unbelievable amount of FTE and paperwork to get done. But again, Mayo had some experience with this, which helped us. We then promised that we would do a prospective data collection for 2 years post-operatively, and we created a review board of adult spine surgeons who weren't doing these surgeries, were not involved in these surgeries, who would then tell us, this is a good idea or you need to stop now. And so we basically had some breaks in there. So this is a little bit about how we do this operation. We do an intraoperative CT guided navigation. This is not atypical for pediatric ORs now. This is a proprietary intraoperative CT scan. We do use navigation mostly because while it's easy to place screws, we want to make sure that we place them in the perfect position, because we're going to ask a lot of these screws as we start to tug on the cord. We can also plan our incisions so that we can make it minimally invasive, as we've previously heard, and that it's not really, it's minimally/maximally invasive. We have navigated probes and taps. You can use other platforms that other people have done, but we've tried to teach others to work within the navigation space instead of fluoro, because we like the three-dimensional view. Just one little side note on pediatric dosing. If you do use intraoperative CTs, try and crank down the settings on the CT scan, because the difference is tremendous. We have lots of publications based on decreasing it to 80-20-80. And we actually now use 7-70-16, because you don't really need perfectly clear 100% visualized space. So if we look at our anterior versus posterior fusion, we could actually do less radiation by doing an anterior fusion or an anterior tethering than a posterior fusion with the same equipment. If we put the camera at the head, we do a thoracoscopy with our approach surgeon, and we do a navigation setup. You can see the frame hangs off the spinous process in the back, and then we place our navigated screws, and there's a picture of one of our intraoperative images. What we don't want to hit is the aorta, which you can see on the far left or on the bottom right, and we want to also stay out of the canal. Unfortunately, there have been some case reports of intracanal screw placement using fluoroscopy. So again, we try and use our navigation to keep us out of trouble. You can even do lumbar curves. We move the psoas back in most cases, but a little mini open procedure is much safer in our minds than trying to do this through tubes. And so we can really get everything up and out of our way when we want to instrument the lumbar spine. So here are some of our pictures. I would argue here we didn't make much of a difference between 6 months and 3 years, but if you look at the beginning, this is a RISR 1 child that curve is going to progress inevitably throughout their life. And then at 3 years, we've now stabilized it. And if you catch them with enough growth remaining, not only can you get it straight, but you can actually have it grow to a straighter position. And so that is going to be where you'll see tether move in the next 5 years, is really figuring out the exact surgical indications where this is going to work the best and hold the spine the straightest. And like anyone, we learned. So I just want to point out that 2015 OR time, oh dang, what did I do? There we go. That OR time, top right, it took us 8 hours to do our first case. And so this was just because we were new, we were trying to figure it all out, and now we're averaging about 3 hours to do them. And so this is what you can do when you put a team together and you really work hard. Our length of stay is decreased, our blood loss is significantly less. Our accuracy also got better. We looked at CT scans afterwards when they would get them periodically, not as a part of our protocol. And our ideal screws are now in the 92% range. So we also have figured out that if you can get them straighter at the time of surgery, they do better post-operatively. And this is the same principle as the Hutter-Volkmann, right? If we leave them crooked, they will continue to bend and put stress on the tether. And so our best patients are those that we can get very straight, and we've become very selective on who actually gets this operation. They have to have a flexible curve, or else it just doesn't work. Because we know that the spine doesn't fuse. This is the child that doesn't want to have the fusion, because not only does it not move over the fused level, but it hyper moves underneath that level. And that causes potentially disc degeneration above and below. Now, we might not at 5 years or 10 years, but it might at 30 or 40 years. So that's what we're trying to prevent. Our VBT patients do move over time. We've shown that with bending x-rays postoperatively, that the thoracic motion is near equivocal to normal results, to non-operative patients. And so we can see great movement side to side. We can see that this is at 1 year follow-up. They also move. But what happens long-term? So here's a child 6 years after her original surgery. At the beginning, we were placing these screws too far posteriorly and they were getting rib impingement. So this child actually had rib impingement pain. So we took everything out and her curve has stayed stable. In addition, we got an MRI after we removed all those screws, and the discs still remain relatively normal. And so this is the advantage, I think, of potentially this technology, is that we can preserve motion. And if the cord breaks, then maybe it preserves the motion and the discs. We potentially think maybe we could do this with even better technology. We're still investigating that, but we're also trying to use decrease our radiation dose, because our C-arm still, we have to usually do 2 spins in order to get it there. We now use this navigation system with a preoperative CT scan. It gives you beautiful images and really a beautiful way to be able to instrument small pedicles in little kids. What is the future too is predictive planning for motion sparing surgery. There are lots of finite element analysis where potentially you can figure out how hard you need to tension it, where you need to place your screws in order to be able to have the best results. So in the end, you have to be brave when you do something new. There's no way around it. There's going to be lots of obstacles and you have to stay the course. We put a lot of great people on our team and we leaned on each other to make sure that we did it right. That is, don't do it alone. If you were trying to do this by yourself, you would have lots of doubts and probably pull out. And then we would try and change the landscape through advocacy. So in 2019, this received FDA approval, primarily based on our data and Philly's data. And then now it even has the CPT code for the thoracic, but the lumbar codes are still in process. So we've been able to change that landscape so that this new procedure can now become more readily available. And that's all I've got to talk about. Thank you.